Go. All right, so our presenter today is Jose Mazariego. He is a first-year PhD student in epidemiology at the CUNY School of Public Health, and he currently works at the Center for Immigrant, Refugee, and Global Health, where he looks at policy-level data sets to examine the impacts of different policies like Medicaid access, safety net programs, on the health of immigrant populations. He also has done work using system dynamics to model human papillomavirus vaccination uptake, which is what he's going to be presenting on today. So take it away, Jose.
Thank you, Rachel. Thank you for the invitation and also for the kind introduction. So this is a work in progress that I've been working on for about a couple of months now. Uh, and this was I presented this work in progress as well as this as at the conference this past August, and it was a model that was previously built by Nasser, who is a co-author in this a project, and I took it as a learning tool to really get more in depth into system dynamics and really uh, do learn a lot more about the field. And I made some modifications, and we've used newer data to try to calibrate the model. And it is an approach, a system dynamics approach to HPV vaccine uptake among adolescents in the state of New York. It's been a work with Dr. Nassim Sambuchi and David Lansbury, as well as Turner Canty, who is a colleague of ours, and Professor Heidi Jones at CUNY SPH, who has done a lot of research in HPV and who has really helped us understand a lot of the concepts in the model as well. So a little bit of background on HPV. I think many of us may be a little bit familiar with this, but human papillomavirus is the most commonly transmitted disease in the US. It is responsible for various types of cancers, including cervical cancer, penile cancer, vaginal cancer, as well as throat cancer. In the US, approximately 13 million people become infected with HPV every year, with an additional 42 million Americans who are already infected with strains of HPV that are very high risk and can cause disease. There are various types of HPV strains that are responsible for roughly 36,000 cases of cancer in both men and women. Many of those cases are usually through the HPV strains of 16 and 18, which are the most high risk strains, which are responsible for approximately 66% of cervical cancers worldwide. A little bit of a timeline of how the HPV vaccine development came to be. In the early 90s, scientists developed the HPV vaccine after it was found that HPV was a cause of cervical cancer. And in the early 2000s, the first trial of the vaccine showed very strong evidence of protection. And it wasn't until 2006, a few years later, after many other trials, the Gardasil 4 was licensed and approved for girls by the FDA. And this vaccine targeted four types of strains: HPV 6, 11, 16, and 18. But it was only approved for girls simply because the idea was that HPV was a major cause of cervical cancer and it wasn't really needed for boys. But it wasn't until 3 years later that the FDA finally approved the same vaccine for boys to prevent HPV infection. And later in 2014, a new vaccine came out that protected against nine strains of HPV. And the CDC recommends the vaccines to be started at an early age, as early as 9 years old, to really receive the full benefits. And the vaccine works best when given before being exposed to HPV, which is one of the major problems with HPV vaccine uptake, mainly because it is not required. It is mostly recommended. And there's this idea among parents that giving the HPV vaccine to their kids may kind of incentivize them to become sexually active, or there's this hesitancy among the HPV vaccine for various reasons. And And that is something that and that is kind of like the main idea that we want to explore in this project. So the HPV vaccine is scheduled as a 2-dose or 3-dose series among 9 and 14 years old. It is recommended to get 2 doses, the first shot, and then the second shot 6 to 12 months after the first one, and they can receive a third shot if the second one was given less than 5 months after the first one. And then for anyone older than 15, there is a recommended dosage of 3, with anyone over the age of 26 that can kind of catch up with the vaccine, but it is recommended that, with the discussion with the providers first. And this is basically the way that the vaccine has been provided over the past couple of years. In the state of New York, which is what we're really interested in looking, and this data includes when I talk about in the next couple of slides when I discuss New York State, I'm focusing on New York State without New York City. Most of the work that we're doing right now is we are excluding New York City simply because there is a very big difference in HPV vaccinations between New York City and the rest of the state, and we wanted to really explore the state of New York first, and then maybe adapt the model to New York City with more data. So in the state of New York, adolescents ages 13 to 17 that have received 2 or more dosage of the HPV vaccine has really picked up over the past couple of years since it was adopted in 2006. This is data from the CDC where when they started collecting back in 2008, we can see a very high coverage among girls, and it has really increased over the past couple of years, but it hasn't really reached the 2030 target of healthy people, which is at 80%. Um, Among boys, it has also picked up since the CDC started collecting data back in 2012, where we can see a very high increase in the early years, and then it kind of has uh, tried to catch up to females, but there's still a gap that exists between females and males simply because of that uh, initial condition that was implemented by the FDA in the early 2000s that where the vaccine was approved for females first. And so there was this misconception that there was it was not needed for males. And so that's why we are seeing uh, a gap between the vaccination coverage between females and males. And this is very similar across the whole US, including the state of New York. But even though the vaccine coverage has increased in New York over the past couple of years, when we look at specific age groups, we can see that there is very low coverage in the younger age groups, younger than 15. Among 13-year-olds, we can see a coverage rate uh, in 2020 of 24.5%, which is less than what the state has been aiming at, which is about 40%. And there's also, like I mentioned, a gender gap that has decreased over time. In 2020, there was a 2.5 difference in vaccination coverage between 13-year-old girls and boys. And the state has really tried to implement a bill that will require the immunization of HPV among adolescents. One of the recent bills was in 2019 that was proposed to require vaccinations for anyone born after January 1st of 2009, but it was never approved, and it has stayed like that without any improvement. What's interesting is that Hispanic and Latinos and Blacks and African Americans adolescents have the highest rates of HPV vaccination coverage in the state, and might be due to insurance coverage. Research suggests that individuals with public insurance have higher vaccination rates simply because it is covered, whereas private insurance is very hard to get the HPV vaccine covered. There are some other programs, but the majority of the time, if you look at data and you can actually go online, and I did not include that graph in this presentation, but if you go online, you'll find some graphs that show Medicaid coverage has really the HPV vaccination coverage among those who have Medicaid is very high compared to the rest of the insurance types. This is a graph of the percent of 13-year-old adolescents who have a complete HPV vaccine dosage. We can see that it varies a lot throughout the whole state. In New York City, surprisingly and very interestingly, the Bronx has one of the highest coverage of HPV vaccine with 67.6% among 13-year-olds. And then we have areas where the HPV vaccine coverage is very low among that age group. Rockland County, which is where I live, right here is 22%. We have, and even Westchester, which is across, has a higher HPV coverage rate compared to areas like Putnam County and Dutchess and Ulster County, which a lot of the very low Hudson Valley areas do have a very lack of HPV vaccine coverage. And also in Staten Island, we have a very low coverage. So it varies differently throughout the whole state, with some counties having higher coverage among this age group compared to the rest. Um, some of the factors that impact HPV vaccine uptake among adolescents is parental perception of the vaccine, which is what we really want to model in this project. And some of the most common reasons for not vaccinated in children is it is not recommended by providers. Um, there is safety concerns among the parents that the vaccine may have some side effects that may uh, put their child at risk of other conditions. They feel like it's not needed or not necessary simply because it is not required and it's not something that their kids really need. Um, a very common reason throughout the past couple of years has been a lack of knowledge. Parents feel that they don't really know much about the vaccine. There is not really much information about it. And a very common reason too is that they feel that their adolescent is not sexually active, and they also have a feeling that getting the HPV vaccine may incentivize that and incentivize their adolescents to become sexually active. Um, and over the past couple years, throughout the COVID-19 pandemic, we've seen a very high increase in vaccine hesitancy among the parents, mostly on the COVID-19 vaccine, but then that has really spread out and has crippled throughout other vaccines, including the HPV vaccine, which is one that is not required. And this effect was very noticeable in the early um, times of the pandemic in 2020 and 2021. And it has really and we can see some data that it has kind of impacted HPV vaccine uptake. There was also a disruption in care and in-person visits during the pandemic, which is where a lot of the conversations between providers and parents happen. That is very important when it comes to the HPV vaccine because it is not something that parents are willing to drive somewhere to get the vaccine. It usually happens during a primary care visit, and during the pandemic, we saw those disruptions in in-person visits that really led to a decline in HPV vaccine initiation among adolescents. This was a study done by Jacqueline Hurth on the CDC data, which is some of the data that we have been using in this model as well. And we can see that what's interesting is that throughout the past couple of years, lack of knowledge has really um, has decreased as a factor for concerns of among parents. So this kind of shows the reason the parents are very hesitant to vaccinate their kids, and lack of knowledge is something that has decreased over the last couple of years. We can see that it was very high in the early initial stages of the vaccine, but throughout the years, it has decreased. And it has really shifted from a lack of knowledge problem to a safety concern, where parents now are more concerned about side effects of the vaccine, what the vaccine might do to their kids, and and that has really led to some hesitancy among the parents, which is something that um, we don't know how it can be, um, whether providers are going to have some impact in the discussion with the parents that can really lead to those uptake among parents who are very concerned about safety. This is again data from the NIS team, which is the survey that collects data on HPV vaccines and other vaccines by the CDC, and usually it collects data among 13 to 17-year-old kids. In the state of New York, we have kind of aggregated some of this data to find four types of parents. And the question in the survey is, how likely are you to vaccinate your kid in the next 12 months? And we have aggregated the responses to identify whether a parents are intending, meaning that they're very likely to vaccinate their kid, whether they're somewhat hesitant, and this is what in vaccine hesitancy is usually called the movable middle. They're very likely, these are the parents that are very likely to be very kind of easily persuaded to move either way, we feel like is a very important aspect in the model because those are the parents that can really become intending if we have very strong provider recommendation and very strong parental interactions. Then there's also parents who are very hesitant, who may not be very intended, but they're also not negating that they're not going to get the vaccine for their kids. And then we identify parents who are not intending. And what we can see is that not intending parents, they were very high in the early stages of the vaccine, and it has decreased over the years, but it has really not gone any lower than about 25%. And it has picked up since 2016. And this could have been due to an increase in vaccine hesitancy over the past couple of years in some areas of the state where we can see parents really are very uh, concerned about the vaccine and they're really not intending to vaccinate their kids. Whereas intending parents, it was very low again in the early years of the vaccine, but it has picked up, but it hasn't really passed anything higher than about 30%. Um, and it has decreased since 2015, and it hasn't reached the level that it was back at the highest level in 2015. Whereas the rest, it has really um, somewhat hesitant parents, they have really been very in the middle. But they haven't reached any level higher than about 38, about 40%. Provider's recommendation. Again, this is something that is very interesting. It was very about 30% in the early years of the vaccine. This is the number of parents who reported that their provider was recommending the vaccine. And it has picked up over the past couple of years with starting in 2012 when we see a very big um, increase in provider recommendation, which could suggest some um, some feedback loops going on that have really impacted provider recommendation among the parents. And we can see that it has picked up, but it hasn't really gone above um, about 70%. It has really stayed in those levels where only about 70% of providers are recommending the vaccine. And this is in New York State as well. So the idea behind this model, there's a few objectives that we want to really um, take into account. One of them is to develop this model to simulate HPV vaccination among adolescent boys. We wanted to focus on boys simply because there is that gap difference between boys and girls, and we wanted to separate those um, those two genders just and focus on boys first. And we want to see how their vaccine uptake is driven by parental attitudes and provide recommendation of the vaccine. And one of the main objectives is to calibrate this model to adolescent vaccination incidence over time. So we want to kind of use data to that provides us with some idea of how many adolescents were vaccinated um, every specific year, whether they got the first dose, second dose, or third dose. And we want to test various strategies to really understand their impact on understand the impact of provider recommendation and parental attitudes on uptake of the HPV vaccine. There's three main components of the model. One of them is the adolescent boys, ages 13 to 17 years old, the parents, and the providers. For the adolescents, we have 13 to 17 simply because we've been using data from that has been publicly available by the CDC, and it has a is data that only covers 13 to 17 years old, and so we have not been able to really expand the model, but we are waiting on some data agreements that we might be able to get more data on younger ages, where we might be able to expand the model to include those younger ages, which we feel like are very important in capturing some of the dynamics in the model. This is the stock and flow of the model. Is very I'm gonna zoom in the next couple of slides, but this is basically what the model looks like without any of the feedback loops. I just wanted to show you some of the stocks and the rates that we are capturing in the model, and it's a very simplified version. The model that we have is a little bit more expanded, and it has a lot of more components, and it's very busy, and there's a lot going on. So I wanted to simplify it to really give you an idea of what we've been doing over the past couple of months. So the first are the adolescents. So in the bottom left, I have the model that I just showed you, and then kind of zooming in to really give you an idea of what each component of the model has. So for the adolescents, we are capturing, we're using an aging chain to really take into account all of the ages and how they're aging in throughout the system, and they can either age without getting the vaccine. Some of them may decline the vaccine um, in some of the in when they get to a certain age, simply because their parents may be just not they really don't want to get the vaccine for their kids, and so they're dropping out of the system, and some of them may age out by the age of 18 without ever getting the vaccine. And we're cutting it off at 18 because our main idea is to really focus on parental attitudes, and we really want to see how parents' attitudes really drive those vaccinations. And after the age of 18, then they might get the vaccine from their providers without any parental guidance. Um, and then they can get the first dose, and then they can either age out after getting the first dose and never continue to get the second dose, or they can continue to get the second dose or the third dose. And then they can age out after getting either the second or the third dose of the vaccine. The second component, which is one of the most important parts of the model, is the parents' hesitancy component, which is here we're kind of capturing um, all the different types of parents that I discussed in the other graph. We have parents of boys who are very hesitant of the HPV vaccine. We have parents who are somewhat hesitant of the vaccine. Then we have parents who are not intending to get the vaccine, and then we have parents who are intending to vaccinate their kids. And parents can come into the system through all the stages, simply because we believe that parents don't simply come in without any prior knowledge of the vaccine. They either have a very either they're very hesitant from the very beginning, they are somewhat hesitant, or they're intending to vaccinate their kids, and some parents may not be intending from the very beginning. And so these are parents of the adolescents in the aging chain, and they can move throughout the system. They can either become those who are somewhat hesitant. They can either flow to not intending. There could be various reasons for that, or those who are not intending, they could flow back to somewhat hesitant. And the rates may be different throughout throughout the whole system, simply because some parents may be less likely to move from one stage to the other, whereas others may be more likely to move around from one stage to the other. And those parents um, who are somewhat hesitant, they're most likely to initiate or become intended parents. And so they might they move into the intending to vaccinate their children, and this is where these are the parents who are in a way kind of waiting, even though the HPV vaccine happens um, very immediately, but we have this stage just to capture those parents who are very likely to vaccinate their kids in the next couple of um, of months in the model, and then they can move and get the first vaccine. And this is basically what I'm showing here. And these are after those parents who are intending, they can move and get the first dose. And these are the parents of boys with the first dose of the vaccine. And then they can get the second dose and get the third dose of the vaccine. This is a very simplified version of the model. In the actual model, we have more stages. We have parents um, who do not follow through on the second dose, and then they might drop into another stage where there are either um, waiting to get the second dose, or they just forgot about it, and then they can either age out of the system, or they can continue and get the second dose after a while of being in that stage. Um, Similarly, for the third dose, there's also parents who are in those stages where they may not immediately get the third dose, but then they might be waiting in a separate stage. And so this is a very simplified version of the model as a whole. And then the other stage is the providers, and these are the um, providers who are we have kind of like a a two-stage system where we have providers who are aware of the benefits, and then we have providers who are recommending. And this is where we think that a lot of the dynamics are going to happen, where providers are recommending the vaccine, and that it's what's driving some of the parental attitudes and changes in the parents' hesitancy system. Um, And so this is some of what we have, where we have um, providers who become aware of the vaccine, and then they can start recommending the vaccine. Um, and so some of the things that we're capturing in the model, we have a kind of like an SRR structure among the parents, and the reason for this is because we really want to capture the impact of word of mouth, which is how parents who have vaccinated their kids and parents who are intending to vaccinate their kids, how they're um, how they might impact those parents who are in these stages where they're either very hesitant, somewhat hesitant, or not intending. So this is one example of the structure. This is very similar among the other areas of the hesitancy structure of the model. But basically, those who are intending and those who have adolescents who have gotten the vaccine, they become in contact with uh, with other parents, and then they can and that leads to some impact of word of mouth, and which might either decrease hesitancy among some parents, or it might even go the other way around, where it might increase hesitancy among the parents. And we're using a weight of word of mouth, and this is what we really want to capture, to see um, how much those word of mouth impact the those rates. And then we're also capturing providers recommendation, and we have kind of like an equation that it just combines both the weight of word of mouth and the weight of provider recommendation, to see how they differ among each of the stages of the parents. So for example, parents who are somewhat hesitant, they might um, word of mouth might have a higher impact than provider recommendation, or it might be the other way around. Whereas, for example, parents who are not intending, they might trust more their providers, or in some ways, they might even trust more their other parents who they know who have gotten the vaccine. And so they're, we really want to capture those dynamics because it is very important. It's something that we really want to explore in this model. And this is just the separate structure where we have uh, kind of like the parents driving the vaccination. So we have those parents who decide to vaccinate their children. Um, they get they have their child get the first dose, and then those that is driving those parents moving from intending to the first dose. And we have similar structure for the second dose and the third dose. Again, this is a very simplified, maybe even too simplified version of the model. Just to really give you an idea of what we're capturing, and if you have any ideas on what we're missing, this is some of the areas that we are kind of exploring, um in that we've been exploring over the past couple of months. So some of the next steps, we really want to gather more publicly available data that can be used to validate the model. um we want to calibrate the model using data from the New York State Immunization Information System. So we've been in contact with this New York State Department of Health, and they have agreed to provide us with some immunization data from their system. And this is more accurate data than what we had. This one of the problems that we'd had with the CDC data is that it is it it just looks at 13 to 17 years old, even though the vaccine is also provided earlier than 13 years old. And but also the other issue is that with the CDC data, we don't have any information on when that child got the vaccine. So, for example, we know that um, a certain percentage of the adolescents in the state of New York have the first dose, but we don't know when they got the first dose. We don't know if they got the first dose in the early stages of the like before they were 13. We don't know if they got the first dose um, in that year that they were surveyed. It just there's just a lot of information that is lacking from the public available data that we have from the CDC. So we're hoping that the New York State Immunization Information System can really provide us with more accurate data that is where we are able to see how many adolescents who were 13, 14, or 15 years old got the first dose um, in 2008, and how many got the first dose in 2010, and so on. And that can really help us calibrate and validate the model better. We want to evaluate, as I mentioned, the impact of word of mouth and provide a recommendation. Those are the two main strategies that we are trying to estimate and calibrate the model. And we want to use that to really explore how changing the impact of word of mouth and provide recommendation can lead to either higher HPV vaccine uptake or lower HPV vaccine uptake. And we want to create a dashboard that can be used by various stakeholders to really to simulate the impact of these strategies on HPV vaccine uptake among adolescents. And that is something that might be later on once we have a model that is calibrated and a model that is valid based on more accurate data. Um, we want to finalize the manuscript for publication. That is something that we've been aiming for. Hopefully, we're hoping to hear back from the New York State Department of Health in the next month or so. And so we're hoping that with that data, we can really calibrate this model and really have some results to share, because right now I'm still working on setting up some of the equations. We really have changed a lot of the structures of the model. So previously we had, and something that I presented on at the conference was that we had parents who were willing, parents who were knowledgeable about the vaccine, parents um, who were aware of the vaccine. There was a lot going on, and so we've changed a lot of that structure, and we really have just kind of changed it into a more hesitancy based structured that really just capture parental hesitancy rather than knowledge and awareness, which might be very difficult to really get data on, and it might also be very difficult to validate. And so there's been a lot of changes to the model, and so we're hoping that we can finalize the results with if we get data, and we're hoping to get that manuscript ready for publication. Uh, Once everything, all of that is done, we're hoping to also expand the model to maybe even recalibrate it and look at adolescent growth and maybe even compare results from this model that looks at boys and see how parental hesitancy changes between boys and between girls, and then also recalibrate the model for New York City, which is something that Professor Heidi Jones, who is a co-author in this project, she has done a lot of research on HPV here in New York City specifically, and she tells us that there's a big difference between New York City and the rest of the state when it comes to HPV vaccinations, when it comes to HPV awareness and hesitancy. There's just a vast difference, and so we didn't want it to include New York City within the whole state simply because of those differences, and we wanted maybe recalibrate the model for New York City and see how that compares to the rest of the state. Yeah. Basically, that's basically everything I had. I know it was not a very long presentation, but I'm happy to take any questions and any feedback, and that will be very helpful.
Awesome. Thank you, Jose. Does anyone have any questions or comments or suggestions for Jose? Oh, Deb, I see your hand. Go ahead.
I just had a quick question. I wasn't sure how much the word of mouth, like how much information, how much data do you have about how word of mouth works?
So for that, we are just using kind of like the number of parents in each at each stage, and we're using an SIR structure that kind of calibrates some of the parameters to see to the data that we have on the number of vaccinations um, among adolescents. So it's kind of a very kind of like a complex dynamic that it is kind of driven by the number of boys that are getting vaccinated, which is kind of shifting parents from one stage to the other, and some of the parameters like sociability, which is how parents interact with one another, and fruitfulness, which is how much of that information um may be kind of like infectivity in an SIR structure, and those are the parameters that are that we are calibrating to the data, and that's kind of what's driving word of mouth. So it's not really any data that we have on word of mouth. It's more of a calibration based on the number of boys getting vaccinated over time.
You might want to look in the psychology literature for information about word of mouth and how it works, and yeah.
That's actually something that I had not thought about. So I will definitely look into that.
I just had a comment. Early in the talk, you used the word aging chain to describe this lower area down here, but this is not actually an age. It's a chain for sure, but it's a more of a vaccination stage of the youths. Or is it the parents? Anyway, my point is be careful about the word aging there. Aging suggests that people are getting older, and there's a fairly specific process for that. The process here is more complicated, and it's should you show it as a one-way process, but isn't it actually couldn't it be both ways? Just a question. I guess that's a question, but a comment at the same time.
Yeah, this is a very simplified. I didn't want to make it very busy for the sake of the presentation, but in the model we actually have stocks for each individual age group. So we have 13, they age into 14, and then they age into 15, and they can either get vaccinated and move into another stock.
Okay. But
Yeah.
that underscores another concern. I know you said this was simplified, but it feels like this is a pretty darn complicated model. And I wonder if this is the right starting point for your thinking to be at this level of detail, because you're trying to characterize potentially not just dozens, even more than 100 interaction effects all at once, sort of. And I just wonder if you might benefit from sort of pulling back up and saying at a higher, could we actually operationalize something at a higher level and focus a little bit more on sort of the feedback structure and dynamics, the big picture, major feedback dynamics, and be somewhat maybe less concerned about getting more and more exact data, instead getting a really good understanding of the influences that drive changes in behavior somehow. Just a thought.
Yeah, that's actually a very interesting point, because that's something that we've been kind of having difficulty. Nasim and I, we've kind of meet every week, and that's something we always go back to the structure, and we always are asking ourselves, do we have the right structure? Are we capturing too much? Because we had so many difficulties really trying to understand some of the dynamics within the parents, and that's why we've changed the structure so many different times. And so I definitely get your point. And so, it's definitely something that I'll think about and see what I can do to really get more in a macro level to really understand some of the structures that's driving some of those vaccinations. Yeah.
Jose, this is Jack.
Yeah.
Thanks for your presentation. I have a bit of a concern similar to Wayne's, which is, as I understand it, this is not a running model, or it hasn't been, you have not demonstrated that this model can reproduce the history that you showed us early on. Is that true?
Yeah, so this is the one that I have right now is not operational at the moment. The one that was built by Nasser, who was the original kind of person that came up with this idea. He worked very closely with Nassim, and they built a model, and it kind of replicated some of the results, but they were not very close to historical results. And so that's why I took on the project to really change some of the structures to see whether it was an issue with the model, or the data that we have wasn't really was very different than what we thought it was.
But at this stage, you have not validated this new
No.
structure. I see. Because, okay, so I come back to what Wayne was saying, which is keep it simple. Keep it as simple as necessary to reproduce the reference mode data for adoption, and also hesitancy, the various categories. And yeah, because you can really get into trouble if it's too complicated too early. That'd be my suggestion.
Thank you.
There's a couple questions in the chat, and I'll just start with the first one. So, Mehdi was curious why you chose to focus solely on boys, and if you think there's a structural difference between boys and girls.
Yeah, so one of the main differences is that how the vaccine was first introduced in the US back in 2006, which was primarily as a cervical cancer prevention vaccine. And so there's a lot of there's some gaps that we are seeing in regards to how likely boys are to get vaccinated compared to girls, simply because of those parental attitudes that they feel like their males are not they don't need to get the HPV vaccine. And so we wanted to really focus on boys first, and see if any of those, if it was any changes in how vaccination rates differ between boys and girls. I don't know if that answered the questions, and it was very.
I guess like the question is probably, do you think that the structure, or when you get to a structure that you're satisfied with, do you think it will generally apply to boys and girls, and maybe that boys just have maybe a different starting condition or starting point? Is that kind of what you're thinking?
No, I think it was more about the parental attitudes that exist between the HPV vaccine for boys and then for girls. At least from the literature that we're seeing, there's some parental attitudes that parents are more likely to vaccinate their adolescents if they are girls compared to boys. So it's more about the parental attitudes compared to I think once we have a structure, I think it might even generalize to girls as well. So, but the parental attitudes might be different.
Gotcha. Let's see.
Hi, Joseph. My name is John. My question is on strategies that you are considering for your model. Can you tell us a bit about that? What strategies are you guys considering?
Sorry, can you repeat the question again? It was very hard to hear.
It's a little hard to hear you, John. Can you maybe speak up a little bit more?
Okay, my question is that what strategies are you considering to test the model to improve the HPV vaccination?
So the question was, what strategies are you planning to test once your model is, once you're satisfied with the structure?
One of the main strategies is providers recommendation. We want to really see how increasing provider recommendation might impact vaccination uptake, and then word of mouth and seeing how the impact of word of mouth might have on vaccine uptake, and maybe even a combination of both to see how they both might impact vaccine uptake. So those are the kind of like the 2-3 main strategies.
If I heard you right, you said that those on government insurance tend to have higher uptake. So why is that not part of the strategies that you are considering?
Yeah, that's something that we've been discussing with Nasim and others who have joined some of the meetings, is that there are big differences in regards to insurance type. But again, we feel like within it, we had a very kind of like to Wayne's and Jack's point, we had a very complex, kind of a complex model, and adding insurance type might make it more complicated. There's also differences in regards to ethnicity, and that might also make it more complicated. And so we really wanted to kind of keep it as simple as possible. I know it looks very complicated, and um, it might even make it easier to get simpler than this. But adding insurance type and ethnicity differences might also make it more complicated.
I noticed based on your maps that you showed that it really seems like there's a big disparity by urbanicity also, which is probably also related to ethnicity. But maybe like some future work could be comparing like urban versus rural areas, or even incorporating some element of that into the model in terms of like attitudes and perceptions. Since, I mean, yeah, this map looks kind of like a population density map a little bit, except for Rockland County. That seems kind of like an outlier.
Yeah.
So that could be something interesting to explore.
Yeah, I think that's a great point. Yeah.
I'm curious about what fraction of boys have a first shot and then don't have any others or don't get the full doses, and whether there are strategies for improving on that. Also, what effect only getting a partial set of a single or two of the three affects the preventive effect of the shots.
Yeah, that's a very good point. Some of the data that from the CDC, we see a very high percentage of both boys and girls that receive the first shot, and then we see a very smaller percentage that have more than 2 shots. So there's a big disparity in that. In that's something that we had also been discussing with our team, is really how what the question in regards to this model is. Have we, do we really want to look at HPV initiation just to get them through the first dose and then see how those changes how they get to the second dose or third dose. And so that's something that we've been discussing. But in regards to the protection, I'm not 100% sure what the protection differences is between getting the first dose and then between those who have the first dose and those who have 2 doses or more. But that's something that is a good point and something that should be explored a little bit more. But I know that there's a high percentage of those who have a first dose and then they never get the second.
Because if your ultimate purpose is to reduce the transmission of HPV, that's probably an important thing to look at eventually. And I can think of strategies, appointment systems, or making appointments for the second and third dose when the first dose is administered, so that there's a greater likelihood that there will be follow through. That's something worth looking at. Probably something I think fairly simple to add to the model.
That's a good point. And I appreciate the feedback. Yeah.
All right. I think we have time for one more quick comment or question. Anyone? Douglas, yeah, go ahead.
Yes, hello. Thanks. That was an awful lot to take in. I just wanted to say a word in defense of your use of the term aging chain. I think that you've basically got two processes, but they're both going only in one direction. So aging chain can tend to be thought of as only about chronological age, but it can also apply to a process which is going from stage to stage with no turning back. So in your case, you've got chronological aging, people going between which one might model using arrays in Stella's language. I think you're using Benson. But you've also got the process of getting one vaccination and then a second vaccination and possibly a third, and that can only go in one direction. You can't go from having one vaccination to having 0 vaccinations. So I think I would allow that, but because it illustrates the challenge that if you've got a window that is between say 13 and 18 ages, when you have youngsters in a position where maybe you can reach them with a vaccination, and I don't know, I mean, at the age 18, presumably they're harder to track. Then you have got this, what's going on here is you've got somebody, they have their first dose and they're still under 18, and you can still possibly get them to have a second dose. So that was one point, but the other thing was, again, thinking aloud about the idea of word of mouth, because word of mouth tends to mean that somebody moves from not having something to having it, and then they're really happy that they have it, and they tell their friends, and their friends want it. And the benefits of vaccination obviously are felt in the absence of something, the absence of the condition, like a condition that you might get in later life. So therefore, if you're vaccinated at the age of 13, when you're 15, you're not telling your friends that you must get this vaccination. So there's a bit of interference there. I don't know if that's somebody telling me I've had enough time or something. So I think that, but you could contrive a word of mouth. So is it done that, for example, boys age 15 who've had 1 dose are enlisted in some kind of public health initiative to tell their friends that I've had this and it's done me no harm? So what does word of mouth actually mean in terms of the typical system dynamics diffusion model?
Yeah, I think in this case we were thinking more of a very minimal idea of word of mouth. It's very simplistic, of parents get the first dose and they tell their friends who are probably hesitant about the vaccine, and they tell them, oh, I got my child the first dose and they're doing fine, right? Especially because we've seen that safety concern is one of the major issues when it comes to parental hesitancy of HPV, and so that's how we were thinking on word of mouth. So more of a parents just telling other parents that they got their child vaccinated. and it's basically and that's we were not thinking of it in the way that you are describing it, and so it's something to consider, I think. But in our idea, it was more of a just parents telling other parents that they got the child vaccinated. That was it.
Okay, I think with that, we are at time. So thanks so much, Jose, for the interesting presentation, and hopefully you got some helpful feedback for next steps on the project. And I don't think we're having a meeting until January 8th, so I hope everyone has a happy and safe holiday season, and hope to see you all in January. All
Thank
right.
you very much.
Thank you so much.
Bye-bye.